Welcome back to another Pitt reaction. This time, we're jumping ahead to one of the most dramatic episodes within the series, and for that, I brought a friend. Please welcome Dr. Donald Pettet back to the channel.
Hey, what's up everyone? I'm Dr. Donald Pettet. I'm a board certified ER doctor, and I work at a level 1 trauma center in New York.
And he's an expert in experiencing what it's like to be in a setting that we're about to see for ourselves with this episode. And a little nugget from this reaction episode, I actually visited the Pitt's set. That's right, here's a little picture. Make sure you watch the entire episode to get all the good stuff.
There is an active shooter at Pitt Fest. As the nearest trauma center, we are going to be getting the majority of the victims. We don't know yet how many we are getting, but we are instituting hospital-wide emergency protocols. We need to move every patient out of here. They either go home, they go upstairs, or they go to family medicine.
So this is like super common in the hospital. They actually mobilize resources from upstairs. They take patients that are gonna be discharged, they move them out. They take patients in the hallway, they move them upstairs to the hallway beds.
And you have a meeting just like that in front of all the other patients.
Yeah, we have a huge huddle, get everyone together and mobilize all our resources that we have together.
So when you say mobilize resources, you're getting scanners, you're getting blood products,
We're getting
IVs.
supplies like gauze, gloves, we're getting rooms, we're taking all the curtains down.
What about backup staff? Are you calling in people who are off duty?
We do activate extra surge staff, but obviously it's availability.
Yeah.
Call your loved ones now if you need to. I can guarantee you self-service will soon be overwhelmed.
Can that happen?
Yeah, and this is some of the things people don't think about. Self-services might be down, our Wi-Fi network might be going down, police might not be able to communicate with us, pre-hospital providers, on what exactly is coming in and how many patients are coming in.
What makes the cell phone service go down?
So many people
Just
at
so
one
many
spot.
people in one spot
So if
calling?
you've ever been to like a Black Friday event where so many people are shopping
That's your-
and literally all the cell phones are together, or like an earthquake when everyone's calling and you can't get out any
Wow.
phone calls,
Okay.
cell phone service might be going down. So
And
it's things like that we
everyone's
don't think
calling
about.
because they want to give an update on what's going on.
Exactly, and they want to check in with their loved ones. They want to say, I'm okay, I'm in the ER, I have a minor injury, or their loved ones are just ringing them nonstop.
Eat something, stay hydrated, use the bathroom while there's time, and meet back here for a full briefing in 5 minutes.
I feel like there's got to be coffee on
Yeah.
deck, ready to go.
Honestly, at this point, I think the coffee's even past that point. I think everyone, when they hear an MCI, a mass shooting, lots of GSWs, everyone's adrenaline surging. It's even
Are you
hard to-
nervous?
Nervous,
Like,
but
how often does this happen in your hospital system?
not often, but we do train for this.
Okay.
And I think it's important that preparation is key for this, because without it, people will get nervous and people will get hysteric. So I think
And that's where
it's-
mistakes happen.
Yeah.
We're going to be putting 4 gurneys in each of these trauma rooms, so make sure you stock both rooms to handle the additional patients.
They're talking about each trauma bay usually only has 1 patient, and now they're expanding to 4 patients. This is very common. We typically put stretchers side to side so that way one attending or one team could take care of multiple patients at once.
How's it looking upstairs?
Should have all 25 ORs running within the hour.
We could be buried by then.
Everyone's rolling as fast as they can.
Surgery's ready. We're here, we're ready.
What's sanitary protocol? Like, you're taking care of 10 patients, there's blood everywhere. Are you changing gloves every patient? Are you disinfecting and fully washing your hands in between every patient? Or no?
So the most important thing is obviously protecting yourself first. So you don't know when there's a mass casualty, if there's decontamination that has to occur, whether it was a warfare event, whether it was a nuclear warfare event. So you see all the staff putting on level 1 PPE, which is the impermeable or waterproof gowns and gloves. And then typically what we do is we put a second pair of gloves on top of that, and that's for the patient, to protect the patient. So we would switch our top gloves in between the patients at minimum. Obviously, if you're saturated with blood, you should be encouraged to switch everything.
Okay, this is yours.
Thank you.
What is that?
Yeah, so right there are the triage tags. So triage is like the sorting out of patients. So normally the patients come in through the waiting room and through ambulances. Those tags are for an MCI incident, a mass casualty incident. First tag is a green tag. Green tag is a minor injuries. We usually call those the walking well patients. Those patients usually do well without medical care even. They just come into the hospital sometimes because they're worried. The second type of tag is the delayed tag. That's a yellow tag. Delayed tags are people who would benefit from medical care, but also wouldn't suffer if we delayed their medical care. The third tag is a red tag. That's the most immediate care. So those patients need immediate care or they will die without it. So in order to give them the proper medical care, those are the patients that are gonna need interventions right away.
Priority.
And then the black tags are either expectant tags, so people who are expected to die without any medical intervention, or are already deceased. So those are patients
That are
obviously
going to die irrespective of medical intervention.
with very low probability
Got it,
of survival. So even if you did intervene, that's somebody with maybe a GSW to the head,
And that's
even
usually
with-
probably saved to be done by the most senior attending.
That has to be done by the most senior attending.
got it.
Yeah, that's the most important role. And a lot of patients might come triaged by EMS with this tag system, but this changes as the situation evolves.
We're going to send all the unstable chest and belly straight up to the OR.
So he's talking about mobilizing resources. All the unstable GSWs to the chest and the belly go straight up to the operating room because those patients are going to need operative intervention to survive.
Our ambulance bay is now our triage. EMS will be overwhelmed. Most will probably arrive by car, several victims per vehicle. For all you newbies that don't know, Dr. Shen is our night shift attending. John, I'm going to put you on point.
And
three.
I'm a night shift attending too. And this is like classic. Like if you go back and look at his face, he's like, cool, no problem. Sits down and finishes his coffee. So he's used to coming into something crazy, and this is just another clear example of what us nocturnists do.
Is it true that as a nocturnist, that up until 2 a.m., 3 a.m., it's a disaster, and then from like 3 to 7, it's more chill?
100%.
Okay, cool.
100%.
That still holds true from
Yes.
my days. Okay.
Every department will have a designated primary who will oversee their staff. If you need someone, look for the vest. We're all gonna have walkies. We can get you whatever you need.
No patient goes into a room unless it's a trauma bay, and they will have 4 patients each. We need to keep everybody out in the open so we can keep an eye on everything.
Are you doing any kind of monitoring in a situation? Are you hooking up people to telemetry, or is there no time for that?
Usually no time.
Okay, triage is going to assess and assign every patient to a specific zone with the colored slap band. Patient who comes in with a red slap band goes to the red zone, which is the trauma rooms.
That's nifty. I like those slap bands.
You don't have those?
No.
Oh, we got to
No,
invest
we have tags.
Okay.
The south and central common area over there will be the pink zone. That is for patients who will die in under an hour without treatment. McKay and Javadi, you were over there with help from incoming night shift and surgical staff.
So they seem like they even further delineate
they have a fourth
red and
version,
yellow.
yeah.
They have a pink that's in between, which is really helpful as well.
We're a MASH unit now. There's no charting, no electronic medical records, no board.
How do we document treatment?
Oh, you'll all get Sharpies, and every patient has a wrist chart to document treatment and procedures. You run out of room, right on the patient's forehead.
Is there any legalities that are associated with this, that like if you didn't chart appropriately and a medical mistake happens, there's understanding given the mass casualty event?
I've never had to deal with the legalities of it, and I honestly have no idea.
Okay.
But
'Cause I would be scared.
I think at a time like this,
You're just trying to do the best.
It's completely different from what we normally practice with, and this is just.
Is it like similar to like Good Samaritan? Like you stop on the side of the road and you're trying your best with limited resources?
I think everyone's just trying to help everyone, and I don't know if there's a correct answer, but I think
we need legal.
Yeah.
Well, legal, we're phoning you in.
This is no frills combat zone medicine. No ultrasound, no x-rays, no CT, no labs. Assessed based on mental status and pulse strength. Every critical patient gets an IO, intubation, a unit of blood, and chest tube if needed.
Is IO just significantly faster from an interosseous
100%.
perspective?
Yeah, I
Okay.
can put an LMA in, which is a supraglottic airway, and an IO in about 10 seconds.
Wow.
So an IO is basically an intraosseous IV. So it's a large IV needle that actually drills into the bone. So we start at the skin, we puncture the skin, and then we use, it looks like a power drill, and drill physically into the bone. And that's to deliver medications. We can actually get blood work off of it and deliver drips like pressors, blood, and fluids, and help the patient. So that's superior in a trauma scenario because of the speed.
Yeah, the speed, and also I'm sure it's difficult to get access. Like someone is completely fluid depleted or blood depleted, they're gonna have flat access, and you're gonna have struggle with getting an IV in. Versus
Exactly.
there, boom, it's in no matter what.
Oh, keep a couple of 11 blades in your pocket.
Yeah, I was gonna say, first thing I do when I hear something like this is put a scalpel in my pocket. And some attendings actually walk around with a scalpel in their pocket from
That
some
sounds like a
emergency.
safety.
Well, they have scalpel guards on it,
Okay,
but
got it. What is the purpose of it? To do an
to
immediate...
decompress the chest. So if somebody has a
Got
pneumothorax,
it.
like you talked about on the other episode, to open up their chest, make a slice, put in your finger, and decompress that chest to let the air out.
The goal is to triage each patient in 10 seconds.
10 seconds. Got
Mental
it.
status is AVPU, alert, responsive, verbal, responsive, pain, unresponsive.
All right, fun fact. Because I was just on the set of The Pitt with our boy Noah Wiley here, I got to see that this front entrance is actually a pseudo front entrance because it's inside of a set. Because if you were to build the entire ER and that, it would take up way too much room. So it's pretty cool to see how they can have continuous shots using different locations. Really cool on that end.
I got 4 shooting victims.
So this is like exactly how it is in real life. Patients might arrive in police cars. They might arrive with friends. They might arrive with fire department. They're not just going to all arrive in ambulances on stretchers already.
Show me. Right chest, strong radial, pink. What's this? That's priority boarding. You're going to be okay.
So this guy's talking. He has good respirations. He has a wound to the right chest, so likely GSW to the chest. So this is somebody who needs immediate care, but it can wait a little bit because he's conscious and breathing well.
Which could change.
Yes, exactly.
And then if it does change, do they peel off the pink and put on a red?
They can just slap one on.
Oh, so it's like if they have the higher one, that one takes priority.
Exactly.
Got it, okay.
What's your name?
I'm Sylvia. This is my son, Omar.
Omar, can you open your eyes for me?
His dad.
Oh, that's hard.
Kids are completely different when you're triaging kids. So they're a whole different level of compensation, so you have to take that into account.
Compensation or what?
For their vital signs, for their breathing, they might not show signs of actually compromise until it's already too late. So they might identify more as, oh, they're a yellow tag or maybe a pink tag when they're actually a red tag. So it's so important.
It works kind of both ways in pediatrics, where I see kids that looked very sick and then suddenly in a matter of hours or days, they're back to normal and fully running around. They healed super quickly. But at the same time, I've seen kids turn where they're like coughing, maybe a little bit rapid, shallow breathing, to completely decompensating and can't breathe at all.
So it's so important to have that senior attending to take a look at every single pediatric triage.
Sir, can you hear me? Black and white peds.
So yeah, this is a patient who has either already expired or who will expire, and there's a very low probability of him coming back. Normally, this is somebody who we can take care of and try to resuscitate and maybe get him to live. But in this scenario, if you try to help him and take away those resources from all those other red tags, you might actually harm more patients.
What happened to your leg?
I got hit by a car when we were wheeling.
Okay, we'll see you inside too.
So we're already at 7 patients, and it's been 2 cars. Critically ill within 2 minutes. So this is a huge volume of patients.
Do they have, who's doing the delegation about which hospital to take patients to?
So
is that happening on the back end with the paramedics?
So usually when an MCI is activated, just like they got paged, there's an ICS, an incident command system, and that's local government, pre-hospital providers, PD, fire, and that's all the resources bundled together to help distribute all the resources. So that's patients going to different hospitals. So
who's deciding that?
So usually the medical director for the EMS crew, the emergency medical
and
services
they're
crew.
in communication with the government.
Exactly.
Got it.
So the most critically ill patients should go to the massive trauma center. The other patients who are more well, they can go to the hour drive to maybe a smaller institution.
Stronger pulse. I'll take her up.
There's a chest tube going in.
It's really pouring out. Squeezing 2 units, 1,500 out, buys them a trip to the OR.
So they're talking about chest tube management. So if a patient comes in, we put in a chest tube and more than 1,500 milliliters of blood comes out. So 1.5 liters of blood instantly comes out. The patient needs to go to the operating room for open chest procedure.
How do you survive if 1.5 liters is coming out instantly?
You gotta fill the tank back up.
That's fast.
Here's an IO going in.
IO's in, go with Opaz.
I would prefer that he punctured the skin first and then started drilling, which is a common mistake.
Because then the
start
skin
training.
can twist?
The skin can actually twist. And you can see, I think it's on a model here, but you can see the skin twisting a little bit.
Robbie, stabilize for the flip.
So you see how they were squeezing in the blood products? We actually have pressure bags, or if you want to use makeshift blood pressure cuffs. Sphygmomanometers. So I would prefer that somebody actually put that on one of those devices rather than squeezing it in, because extra set of hands is extra patients that we can take care of.
And for people that are wondering, why would you squeeze it? When you squeeze it, you're not just relying on gravity to bring the fluids down or the blood products down, you're actually increasing the speed of that transfer.
He's got a wound on both sides. He's gonna need 2 chest tubes.
Yeah.
Need a hand?
Hell no, I got 2 hands.
Roll.
How important is doing a full body scan, like getting patients fully undressed, doing a full body examination to make sure that you're not missing a knife wound, a gunshot wound, an exit wound, and totally mismanaging that patient?
So important. I have so many patients that come in and they say they heard a gunshot and that they didn't get shot, and we take off their pants and they have gunshot wounds through their legs. Yes, it's wild. It's wild because people have so much adrenaline from being shot and they don't even feel it. They just are so hyped up from what's going on and in shock. And then all of a sudden we take off their pants and they have 2 gunshot wounds on their thigh. It's wild.
It's
so important.
I've had that happen with, like, I ask if a patient has a rash on their back and they're like, no, I don't. And then I check they have a rash. I thought that was wild. But you're talking about it with GSWs.
Hi, Sylvia. I'm Dr. King. Oh, Oh, looks like closed tib fib fractures.
Strong pedal pulses, great flow with the butterfly.
So you probably wouldn't
So-
do anything in that situation for
Yes,
now.
so that would be probably a green or,
Yeah.
or maybe a yellow tag.
In a situation where you have a patient with compromised vascularity because of an open fracture, or perhaps a closed fracture, but one that's impeding on blood flow, are you reducing that right then and there?
100%. Yeah, I think if this is my patient and this is my sole responsibility right there, I would try to reduce it, regain vascularity, and then move on to the next patient.
Okay, I got separated from my son, Omar. He got shot in the chest.
Okay, I'll let you know as soon as I find out anything.
He is deaf, ASL only. They need to know that.
Okay, I'll make sure it's in his chart.
She needs x-rays, AP and lateral.
Well, radiology's gonna be closed for hours. Put her in a long can boot and pain meds. We're just gonna make you comfortable.
Great job, right?
Yeah,
That's what should be done. How hard is it during a situation like this managing people's emotions, the patients or the loved ones?
So hard, extremely hard. Because there's going to be, I mean, right now, her and her son are both patients. So that's how they both made it to the ER. But there's going to be a wave of family members coming and asking about their families. So social work and all the other resources from upstairs that we talked about are going to be so essential in a little bit.
17-year-old with a right chest wound?
Going up to the OR now.
Hold on 1 second. They need to know he's deaf when he wakes up.
This is Grayson Cooper, 68. Bullet grazed his scalp.
I got lucky. Dude just clipped me.
You got a headache?
Not really. Little burning.
Good for yellow.
Been to a million concerts. Whatever happened to peace and love, man?
This is like a patient that you quickly
You
throw
don't
some
think about,
gauze on,
yeah.
maybe you throw
Pressure.
some staples in there, and you do a pressure dressing, and he's a yellow tag.
Should be numb.
Israeli bandage starts with hemostatic gauze, then turns into a pressure dressing.
So hemostatic gauze is actually gauze that has protein factors impregnated in it. Basically, those protein factors help the blood clot.
So in a situation like that, you wouldn't even need to apply more pressure from like a tourniquet. That's sufficient?
Well, first you would pack the wound with that gauze, and then basically you would do a pressure wrap. If it's a wound that's arterial bleeding, regardless of how you pack it,
You need the tourniquet.
it's going to need a tourniquet.
And it's like, you need one of those commercial tourniquets, not like a dress shirt tie.
Exactly.
Is that arterial?
No, but it's bleeding pretty briskly.
For people that are wondering, why are we pointing out arterial? Because arterial bleeds much faster. It's a high pressure system. So if you ever to get a significant amount of a cut and you start seeing it spraying as the heart is pumping, arterial bleed.
Yeah, and usually the data suggests about 45 seconds from a femoral artery, which is the big artery in your thigh. If that's bleeding, 45 seconds before you're dead.
Looks like she got trampled. Unresponsive in the field, 3 more in the rig.
So that's another thing. There's secondary injuries to every primary injury. So just like a blast event, there might be the initial blast, and then there might be patients who are thrown or something hits them in
Or
the head.
smoke injuries.
Exactly. So just like this patient, she actually got trampled, and that's by people trying to run away from the gunfire, maybe.
Strong pulses. Okay. Assess for blunt head, chest, belly.
With you?
Anybody.
So this is wild. Like as a medical student, it's your first day in your sub-internship, and they're like, here's your patient, assess the whole body for a blunt head injury. This is cool.
A lot of pressure.
Yeah.
But if that's what you want to do, that's great. If
Yeah.
you didn't want to do that and you're just there part of your rotation, that's really frightening.
It's gonna be a tough
Because
day.
like if you're trying to go into psych and you're there, or like pathology or something, that's as a third year,
it's
that
not
would be
gonna
tough.
end well.
I remember I did my 4th year rotation in the ER at Newark Beth Israel, which I believe is a level 1 trauma center, or
It
it
is,
functioned like one in the moment because they had someone just get dropped off out of a car while I happened to be outside, and he was bleeding out of his femoral, like the femoral area, I guess. And I had to put my hand there without any PPI. And we dragged him in. And then I remember after we got him situated, I walked to wash my hands right away because that's the first step of infectious protocol from occupational health. And after I did it, I walked back. I saw the custodial staff member, the environmental agency, goes, "What are you doing?" And I'm like, "What?" And I tracked blood across the entire, like I did a circle because I didn't know where I was. It was one of my first days. So I'm like, sorry, my bad.
Responsive pain only, thready pulse, chest wall contusions with blueprints on it, sir.
Yellow here, wheelchair.
Okay, sounds good. You need anything? Well, I was hoping for Thanksgiving and Christmas off this year. We can talk about it later.
And this is like classic ER doctor stuff. This is like
Inside
in
jokes.
the middle of a crazy scenario, you're taking care of patients. We might just crack a joke to each other or talk about some other stuff. And this is kind of how we cope with our trauma. It's a reaction. Some people might laugh, some people might crack a joke. So if you hear us making an offset comment, it's probably because of this.
So
Sylvia? Whitaker? Sylvia. Sylvia, can you hear me?
You can already see the volume and noise of the environment is getting louder and louder.
And
more
how easy it is
chaotic.
to miss the situation like this. Oh, she's tired.
Exactly.
I lost her radial pulse.
From a broken leg?
Well, what did we miss?
I don't know. Heart attack, another injury from the car crash?
That's for pulses.
It has an E-fast mode.
If she has no pulse, why aren't they doing chest compressions?
So chest compressions is super important. Somebody should be doing chest compressions, and I think they're looking for a belly full of blood right now with an EFAST. But again, this is a patient that has no external wounds, so she needs to go upstairs if the EFAST is positive.
Diagnosis made.
So right there, boom. So you can see that black area, that's all fluid in the belly, and Morrison's is one of the popular spaces that blood collects. It's one of the first
Retroperitoneal
places.
space?
No, it's actually in the peritoneum.
Okay.
And so basically we're looking inside the belly and boom, that diagnosis is made within a couple seconds. So she needs to go to the OR.
Within my training, it was always said that the retroperitoneal space is where blood can hide very easily.
It can, yeah, and that's one of the limitations of ultrasounds.
Ah, okay, got it.
Car hit the belly. Leg was a distracting injury.
Drill in an IO. I'm gonna get some blood and then we'll move her to pink.
So she needs blood in the operating room.
So like right now while they're doing all this, she's pulseless.
So I don't know if they said pulseless or thready pulse.
Oh, I thought you said I don't have a radial pulse.
I lost her radial pulse.
Just sent another up to the OR. I got room for one more red.
On it.
Didn't make it. Going to Pete.
Another red and trauma 1.
Copy that.
Dana, right.
Careful, kid.
There's your blood splatter
Yeah,
from,
exactly.
from your
That
medical
was me,
student
my bad.
semi. And things can get dangerous. You know, when you're walking around, this is obviously
sharps,
a joke,
yeah.
but there's sharps everywhere. People are doing procedures rapidly, so people might not
Bumping
be
each other.
disposing of supplies, bumping into each other. So you got to be careful.
And the sharps containers are there, but they can overfill very quickly.
Exactly.
They're not like huge.
Yeah.
I need Rainy clips and a unit of O-neg.
Rainy's left to come down from the OR.
I need them now. Okay.
Okay, I'll get him. Oh, neck here. Here you go.
I've never seen blood thrown in my life.
Not much blood, but a big rush of air. Got trampled, collapses lung, tension pneumo.
So another chest tube. I think we're at like 10 chest tubes so far.
I need 0 form, cut 4x4s, and elastoplast tape.
You're here.
So the other thing you can do for this lady over here is something called a REBOA. So if you're assuming that somebody has an intra-abdominal injury, you can stick a big balloon inside the femoral artery and actually occlude the aorta to stop the bleeding anywhere further down. I'm not sure if they're going to do a REBOA on her, but that's something to consider.
Doesn't that then occlude the artery fully and then it's basically like
It
a tourniquet,
does, it
internal
does.
tourniquet.
Yeah, it does, yeah.
So you can only keep it on for a certain period
About
of
60
time.
minutes, yeah.
Okay.
We thought it was just a tib-fib fracture.
Then we found an occult liver laceration.
Leg is low priority right now. If she stabilizes with blood, she can wait an hour for the OR.
And if not?
We're on the line, baby.
Your son's in the OR with the GSW to the chest.
Sweet. Family reunion and post-op.
Whitaker, I'll be right back once this unit's in.
Hey! Good catch, you two.
Hey, Len, we're out of 0 form. I'll try to find her.
That's one unit in. Her pulse is stronger, but she needs more blood.
Not today. Only 1 unit if the pulse picks up.
That's wild.
Yeah, it's wild. I mean, this is the limitation of resources.
1 unit of blood isn't going to do much.
Nothing. It's rarely going to change anything if you need blood in
Like
this scenario.
maybe buying you a minute or two, like if you're massively bleeding.
And you could bolus them with fluids, give them other products, but blood is what they need.
And why we constantly tell people to donate blood.
Exactly. It's so important, and our blood bank might be overwhelmed, especially with blood that we don't know what the patient's blood type is. So we're using all of our bank of O negative, O positive. You can see like 10 stretchers lined up, all receiving a unit of blood.
What's the most amount of blood you've given a patient units-wise in an ER setting?
I would say close to 30 units, and that was at one of my trauma rotations in residency, and that
Baltimore?
was in Baltimore, and that was one of my gunshot wound victims.
Wow.
Yeah.
Did they survive?
No, he passed.
Is there any word on Omar? He's this woman's deaf son, teenage boy shot in the chest.
Kid got lucky. Missed the aorta. He should pull through.
Oh, that's amazing. Well, her name is Sylvia. Would you please tell her about her son when she wakes up?
Unresponsive, even to pain. No GSW, strong pulse, but tachycardic and diaphoretic. Looking for internal hemorrhage. Fast negative.
Help me, Roller.
Tim, Ampa D50 now.
Got it.
Seriously?
Look, glucose monitor. She's diabetic and probably hypoglycemic.
So check a blood sugar.
Well, these days, a lot of people are wearing CGMs for no reason.
This is like the true ER doctor speaking up in a trauma scenario because trauma is basically an algorithm.
Yeah.
And nowhere near in our trauma algorithm is dextrose stick.
Yeah,
It's not. So this girl might be comatose because she's hypoglycemic. But also, like you said, a lot of people are wearing CGIs
Yeah,
for
but
no
it's
reason.
harmless to give
exactly.
dextrose,
Yeah.
a
So
little sugar.
one of our comatose cocktails used to be Narcan, dextrose, just to figure out what's going on with people.
My spidey sense is telling me she took her morning insulin, but she skipped lunch. She's in a coma from low blood sugar. Will you look at that? These are healing hands.
Too bad they're so tiny.
Hello, what's your name?
Dawn, where am I?
Pittsburgh Trauma Medical Center. You dropped your blood sugar, but you're gonna be okay.
Guess you don't need me here? Don't even say it.
MCI 33 to yellow for monitoring. What are you doing?
Ran out of laryngoscopes, no time to autoclave.
Wow. Autoclave is the disinfectant that we use for certain tools that are reusable. Not all of them are. A lot of them are single use, but some are reusable because otherwise there's way too much waste. So.
This is wild. I mean,
you've never seen this?
No, I've never seen this. This is a scenario, again, if we were going to put in the LMA, that wouldn't need a laryngoscope. You just need sometimes a tongue depressor, and you just insert the LMA. So in a scenario that you're running out of laryngoscopes, you can use other ones. Like this is a Mac. It has a curved blade. There's also a Miller, the one with the flat blade. And then there's also ones with video laryngoscopy. So you can also use non-standard measures.
I need suction.
We don't have any.
Too many secretions, I can't see shit.
Here, wipe it out with 414.
Are you kidding me? You guys have a fiber optic laryngoscope?
Nope, just a rigid glide scope. Except we don't have any room for it, so just pull out one bag for a minute.
When did this guy last eat?
We never know down here.
This is funny.
The
This
anesthesiologist
always
is-
happens to us in
Really?
the ER. It's like, when did the patient last eat? And I love our anesthesiologists. They're the best. But I'm like, this
doesn't
patient,
matter.
obviously we have no idea, and they're already a horrible occluded airway. So let's just get this done.
Hold on. Oh, yeah, this is a tough one. Yeah, this one looks tough.
No shit. Prep the neck.
Hold on, okay?
Yeah.
Come over here and just give me a chest compression.
CPR, did we lose the
No,
pulse?
just give me one good push. Yep, okay, give me two.
Was that for him to see where blood would splatter from?
That would probably regurgitate some air from the stomach to make the esophagus kind of burp, and he would see if that was the airway or actually the esophagus.
Do it again.
And I'm assuming you're not checking placement of these things.
I
during
think
the
we're
moment
just
of
using placement by different
Listening
measures.
with
So
the
we're listening to
stethoscope.
both breath sounds. We're seeing fogging of the tube. Maybe we would see color change.
Check the end title.
Yellow, we're good.
Yellow is for good, for gold. Purple is for poopy or not good.
That's a great way to memorize.
Bubble intubation. You gave the compression and followed the air bubbles up more than one way to tube
There
the
we go.
cap.
You can also do a blind intubation just with a bougie, which is like this elastic tube that we can just stick in the airway, and you can just put it in and try to. It has a little curvature at the top, and so you can try that. And if you're unable to visualize it,
Intubated, chest tube, but massive subcutaneous emphysema. Air from the chest is leaking under the skin. Loosen the pulse.
What do you think?
Tamponade from pneumomediastinum, about to cut blowhole incisions to release the air.
yeah. So this is somebody who has, in the previous episode, they had tamponade, which is closure of the heart from blood surrounding the heart. Now this person has an internal injury, leaking air into the cavity around the heart. So they're gonna relieve the air from their heart by creating an incision.
Yep.
And that hiss is like the most satisfying noise ever. The room literally goes quiet
For
when
people
you
to hear.
when you hear that air, and it's like everyone just lets a sigh of relief out when that happens.
Chest tube, please.
We're out of chest tubes.
What the hell? You could have told me that before we started.
I didn't know.
I already made the incision. Now what am I supposed to do?
That's wild. So I would put probably a laryngeal tube in, so an ET tube, the same thing that we put in somebody's breathing.
Just a different gauge.
Exactly. Or you can put like an NPA, a nasopharyngeal airway, which is just a rubber tube that goes in your nose.
What about this?
An ET tube.
There you go.
Tube's a tube, and if you inflate the balloon, it won't pull out.
Fine, set up a thoraceal.
Out of those two.
Oh, for the love of God.
Urine bag?
How am I supposed to connect to that?
Christmas tree adapter. That'll work.
So basically, you're talking about an adapter that has two ways, and then they're connecting it to the ET tube, the endotracheal tube, and then to a urine bag to collect the blood or fluid.
This is all very unconventional.
No, this is genius.
Mel, I need you to reassess, please, now.
Sylvia? Her Her pulse is weak and thready. She's bleeding out from her liver lag. I need Oneg.
Oneg's gone, honey. Glory's got more flying in. Incident command, what's the ETA on our blood?
So that's the incident command they're calling, and that's probably somebody external.
No, she needs blood, not crystalloid. Can she go to surgery?
All right, she's next to go. As soon as we get an open OR.
She's not gonna last that long. Dr. Robbie. Dr. Robbie! Dr. Robbie, we're out of Oneg, but I'm Oneg. Can I donate?
Glory's got more blood flying in.
But I need it now.
What is our blood status?
Just use the last units of Oneg and O-pos, more flying in.
ETA?
Less than 10?
Some patients are not gonna last that long, and I'm sure there are other Oneg donors that probably work
It
here.
would take hours to screen for HIV and hepatitis.
Well, I have neither, and I donate all the time.
So she's more useful treating patients, unfortunately, than donating her blood and tying her up for 15 minutes. So this is one of these ethical kind of dramas that we have to deal with.
Sure. So
and this
you're
is what
her
she's going
attending.
through.
What do you say?
I would say let's keep moving. Let's give her some crystalloid and keep moving.
You and Noah are on different pages.
Listen up. Central 789 is now the blood donor center. Anyone who's Oneg or O-pos, we need you to donate now. Hands where I can see them.
See, to me, that makes no sense.
That's
You're
what I'm
taking
saying.
way too much staff.
That's the problem.
And 10 minutes. You're not going to get it faster than 10 minutes, and it's going to be disease-free.
And so now this patient might get another unit or two of blood, but who knows if she'll live.
Yeah.
Can I have your attention, please? My name is Kiara Alfaro. I'm an emergency department social worker. This is Lupe Perez, one of our ward clerks. I know you all want information about your friends and family. In order to help you, we have a QR code you can scan for our patient identification website.
That's high level. Are you guys doing that now?
That's epic. No,
Oh,
not yet. The Pitt's making waves.
Once you log on, send us the name and birth date of whomever you're concerned about.
If you could tell us what they were wearing, upload photos, pictures of tattoos.
And this is exactly what we do in the hospital. Like during COVID, we repurposed certain areas of our hospital to accommodate different scenes. Like this was patients being notified of loved ones. So this is like a pseudo waiting room family area, but it's actually their staff cafeteria.
We literally transformed, I believe, our psych ward during COVID to be a COVID, like a makeshift ICU ward.
Exactly.
We gave a tour of it on the channel, but it was incredible how fast the environmental team, the engineering team, all came together to make sure that there is negative pressure rooms, that there's visualization of certain rooms.
Supplies,
Yeah, because
everything, the
if you
oxygen
can't
delivery.
visualize certain patients from a certain angle of the nursing station, it's no longer a good ICU location. So a lot goes into it.
So much.
Actually, I talked to the people that write for the show and the producers of the show, and they said that the way that they designed the ER was designed by one of the leading experts who designs ERs in order to have the best patient flow.
Yeah, 500 of saline in. She's barely with us now.
Okay, well, this unit of whole blood should help.
So she has a humeral IO, which is in her arm, similar to a tibial IO. And then we can also do a sternal IO. That's for patients who have usually 4 extremity wounds.
Need some help with an airway?
What is it?
GSW to the neck.
See, like,
Yes.
the transition of taking care of one patient, their blood to the other patient, it's gonna happen.
I mean, in this scenario, it seems like things are already getting very chaotic. So I think they're doing what they can. But definitely, if you can switch. But you might run out of gloves too. That might be another consideration.
With expanding hematoma and distorted anatomy, can intubate him, probably hit the carotid.
So this is a patient with GSW to the neck, so gunshot wound to the neck. Very, very dangerous. You're gonna have bleeding internally and externally. It's gonna compress all the structures. It might distort the anatomy, so even doing an external airway like a crike is gonna be very difficult. Thankfully, it looks like this external anatomy is still preserved, but she's already talking about edema inside the vocal cords.
Give me a 6.5 and a bougie.
So he's talking about doing, setting up for an external airway.
It's too bloody to see a bougie.
Not for this 3-step process. Step 1, scalpel.
Oh, he went horizontal.
Yeah.
You have to, and that's just a scenario? Or
No,
is that
no,
risky?
he should have
should've
went
gone
vertical.
Step 3, bougie. Okay, railroad in the tube.
So they use it as like a guide?
Good, that's far
Yep.
enough.
So we call it the Selzinger technique. So we put the bougie in the airway first, and then basically over the bougie, we put over the endotracheal tube and kind of switch them out.
Got it. So
And
treat
then
it
at
like
the
a guide wire.
Yeah, and at the same time, the other attending is using that Foley catheter, which usually goes inside the urethra. to drain urine, he's using it to occlude that neck wound and block the bleeding from there. So that's pretty epic.
Look at that. Dry as a bone.
Room for another red.
Dr. Walsh, you have an OR for a head and neck case, MCI 48.
We've got 16 ORs up and running. We've got room for one more.
Liver light came back after a second unit. Needs an X-lab.
Turning over 2 ORs now. Send them up. Robbie.
Let's ride.
Oh, right on.
Eviscerated bowel. Fresh ABD and saline.
Get back for a sec.
3.375 Zosyn and a sterile dressing.
So they're just giving some antibiotics and dressing it.
Yep. Yeah. The important thing for this patient
yeah.
is not to try to push it back in forcefully. They're going to put some saline on gauze, and they're just going to cover it, and maybe try to reduce it. But obviously, this patient needs the operating room.
In a situation like that where there's so much blood, you probably have to run the bowel, right?
Of
and
course.
make sure that there's no
Especially
damage
like
there.
what caused the bowel to eviscerate.
What's with all these bloody handprints?
That's from people trying to stop us to get a ride in, but we were already packed.
Chest, belly, arm and leg, red, pink, yellow, and a lucky green.
2 gurneys, 2 wheelchairs.
Oh, these are the drop-offs that get
Coming
dramatic.
in hot.
Carter's in bad shape.
What's his name?
Rich Stefano.
Hey, Rich, how you doing?
You got shot in the face? No, injured on the other side. Neck, above his vest. Cheek is the exit wound.
Okay. Come on, red zone. He needs an airway. Come with me.
Come with me. I got you. We'll get you fixed up.
How is he walking?
I have no idea.
Take him.
Oh, okay. Somebody should have dropped some pressure on there. I know he
Yeah.
was holding some pressure on
But
that right side.
On the wrong side, yeah.
Yeah, well, I think he was holding on the exit wound that they were talking
Yeah.
about, but on the other side,
Yeah.
somebody put their thumb in there. That's the time that you got to come
Yeah.
in and put your thumb in there.
Hey, what's up with the SWAT team?
It's just a precaution in case the shooter heads this way.
Is that a possibility?
And that's the other thing that we always talk about in the ER, especially with gang violence. You know, people might come into the ER.
For retribution.
Exactly.
Do we take these?
Very clearly labeled.
Behavioral health?
Trauma rooms first, then we'll make our way out to the patients in the hub.
Got the ONEG delivered?
Yeah, straight from the roof.
Jesse, hang the unit, then right up to the OR. Who else needs blood?
Everybody.
It's probably like 20 or 30 units in there.
It's not even that
yeah,
much.
not a lot.
The blood's here.
Squeeze my in as fast as you can.
Back for me.
So they're doing chest compressions on this patient. That normally would never occur. A patient who would require chest compressions would be a black tag and go to the expectant area.
Hi, I'm Dr. King.
Buster Pirelli.
I take it you're a children's entertainer?
Impressive observational skills.
No active bleeding. Can you tell me your pain on a scale of 1 to 10?
At least a 3.
And can you wiggle your fingers?
Uh-huh.
Wrong hand.
The other hand.
Uh-oh.
Well, it doesn't seem like you have broken bone, but we're going to put you on some IV antibiotics and some pain meds.
Got it. This is a scenario you'd probably want him undressed, right?
100%, especially with all the
A single
accoutrements and
wound, yeah.
everything.
Okay, you're gonna feel a little pinprick here.
He didn't do the skin either.
Interesting enough, there's a lot of videos on YouTube. IOs don't actually hurt going in.
Yeah.
I know that sounds
But
wild.
unless you twist the skin.
Unless you twist the skin.
Yeah.
So IOs only hurt when you actually push that first flush or medication because it kind of expands the bone marrow. So there's videos of people just putting an IO on themselves and not hurting at all and taking it out.
Okay, why'd you do that?
Dr. Robbie said everyone gets an IO.
If they are unconscious or unresponsive.
If the patient is awake and alert, it's just a standard IV.
Obviously, in this scenario, I think an IV would be more appropriate than an IO.
Blah, too much blood. Move that killer to the right a little bit.
Any better?
Not really. Radial pulse?
Still has it, maybe a little weaker. I can try and give you a bubble.
Yeah, go for it. No, nothing. I'm not seeing anything. Okay. This bag, I want to prep the neck.
How is he still alive?
I'm not sure. I mean, if this is somebody who now is comatose, who's lost their airway because they have swelling, this is somebody who probably needs to get criked on the first try or needs to get a black tag.
Got a tactical airway in my bag here.
What is that?
It's a control crite kit.
Oh, that's perfect. Use that on the battlefield.
Works in the pitch dark when you're under fire. I can do these with my eyes closed.
They actually sell a keychain. This anesthesiologist made this keychain that has a trocar that's actually used to stab in somebody's neck to create a crike if you need an emergency scenario.
Knife leaves a tray hook behind, so you can't miss, right? Just
lift. Wow.
Yep.
Slide in the introducer. Okay.
That was smooth.
The tracheal rings, good. Bob's your uncle.
That was incredibly fast.
A little concerning because there was absolutely no bleeding
Yeah,
when he
exactly.
did that. So either the blood's on the floor or he
he's
just did
not.
it super smooth.
Yeah.
Who do you have?
Semi-conscious, only responds to pain. Decent karate.
Strip him.
Oh, left upper quadrant entrance.
When you're hypoxic, you can get like this.
Oh, 100%, or even hypovolemic. Like if you have no blood, you might start thrashing at people. You might still think you're in the trauma.
Because the brain's not getting enough circulation, either because of lack of pressure or because of lack of blood, basically lack of oxygen going to the brain. And the brain that has the decision-making capacity that's able to recognize that they're in a safe place is not functioning.
Whoa, good! Good! He's going for his gun. Stay down!
And this is one of the scenarios we never know in the ER. If patients have an active weapon on them.
All clear.
You sure?
He's unconscious. Everybody back to work.
Agonal breathing, heaving
Oh, that's not
airway.
Working on an IO.
Drawing up ketamine and sucks.
Yeah, have at it.
Failed IO. Guy's huge. Needle won't reach the bone.
So there's different sizes of needles too. So this is somebody who I would use a little bit longer of a needle. It's usually a blue needle. Pink for peds, yellow for everyone else, and then blue for longer.
No pulse. Start compressions. Okay, get him up.
So you're saying they wouldn't be doing this?
I'm not sure if they lost pulses because of the intubation, because they said they paralyzed him and sedated him. So sometimes if a patient has very low reserve, meaning they don't have a lot of blood supply or a lot of oxygen like we were talking about, because of that sedation, his sympathetic nervous system dropped and that caused him to go into cardiac arrest, or if basically his critical illness caused it. If it's critical illness, then probably it's a person that's not salvageable. If it's a person that they just got
Had a
that way because
reversible
of the
thing,
medications, that might be somebody they might be able to bring back with one round of CPR.
Trying to get him back with 2 liters.
Oh, did they just lose the ET tube?
Kind of look like it, right?
Trying to get him back with 2 liters.
Oh yeah,
it totally was. It was
well,
actually,
that's an acting thing.
It was actually Dr. Ravi too.
Yeah.
So that's something that's super important. Once the tube is in, it's one person's job to actually hold the tube. We actually have a tube holder. It's on some of the patients you see. And basically, if you don't hold the tube and you lose the tube, this was already a very difficult airway. It's gonna be even more difficult the second time going around.
Keep at it. We'll get him back.
Robbie, you need help here.
Langdon?
Keep squeezing.
There's the pressure bag.
What are you doing?
Give this guy a chance. He needs a big central line for a fast transfusion.
You can't do an IJ without an ultrasound, especially on a guy this big.
You'll kill him if you collapse so long or hit the carotid.
I'm not doing an IJ. I'll hook that bloodline, bring it up here. This is a supraclavicular subclavian. If you have to go in blind, this is the only safe way to access the giant vein.
I love that he's putting the sterile field kit out.
Yeah, I have no idea why he's doing that, and he's probably not going to put on sterile gloves.
Yeah.
But this is a procedure we do mostly in trauma victims too.
Oh, you do?
To deliver large amounts of blood in that patient that I was talking about before that we gave about 30 units to. Every patient that comes into that trauma center gets a clavicular line, subclavicular central line, and also intubation.
And you do it blind?
Blind.
Wow.
I'm in.
Nice.
Dark blood?
Okay, resume compressions.
Although dark blood in a patient with no compression, with no blood flow is deceiving.
Exactly.
Hi, I'm Dr. Whitaker.
Ketamine?
It's nice to meet you. I'm just gonna take this. Hey.
So that's pretty concerning right there, because if she needed a tourniquet, you would have to do something called a junctional tourniquet. This is more at a junction of two kind of areas. So the skin crease in your thigh, the skin crease in your armpit, your neck, those are junctional areas. So the best thing to do is either put an elbow or a knee or something small like a lacrosse ball and compress directly into that site if you don't have a junctional tourniquet.
Hey. No. Inguinal GSW with active bleeding.
Try an Israeli bandage.
Yeah, so an Israeli bandage is another type of hemostatic bandage. Basically, it's rolled up gauze and then some stretchy gauze that goes around it.
There was so much blood, I tried to stop it.
Jake?
Robbie, Leah got shot, it's really bad. I've been putting pressure on the wound the whole time.
Yeah, that's good. Are you shocked?
I don't know, maybe my leg, but most of this is her blood.
Somebody you know, boss?
Yeah.
Can't feel carotid.
Start compressions. Swap out with me. I need an IO. Hang a unit of ONEG.
Got the IO.
I'll be right with you, sir. My mom would be very happy. She always says, wear clean underwear in case you end up in the hospital.
So many people tell me that.
What's that?
Wear clean underwear just in
Oh,
case you go
really?
to the ER.
I feel like there's so many other good reasons to wear clean underwear besides go to the ER.
Please wear clean underwear when you come see me, though, if you can.
Whitaker, old hippie's looking pretty out of it.
No, he's sleeping.
No response to pain.
Shit.
So this is the upgrade in that triage. So he went from a pink to now a red.
He's gonna need a head CT.
He's not getting one anytime soon.
Equal and reactive, no blown people. Excuse me, I think I'm still bleeding.
I'll be with you in a minute.
We're back ready. Here you go.
Just when you think it's all stabilizing, it's actually happening in the other direction.
Exactly.
Supplies are running low, people are fatiguing, more mistakes are being made.
1,400 of blood out the chest, first unit's in.
Squeeze in a second unit fast, and then we'll do another pulse check.
You need the second line?
For FFP and platelets.
You sure, Robbie?
Is this emotional reasoning because he's...
Yeah, so it seems like at this point he's working hard to save her because he's invested emotionally. So this is a conflict of interest. So if he could swap out with another attending, I think it's beneficial for the group because he's now adding additional resources, additional products, additional lines.
South corridor, social worker to the south.
You can't be in here.
They're working on my girlfriend. I need to see what's going on.
What's going on is you're losing a lot of blood. You're gonna pass out if we don't stop it.
No, I'm not moving, man. Leave me alone.
Jake, get in the damn wheelchair.
No!
Now, go!
2 units, Pat Stell's in. FFP still going?
Almost there. Okay. Holding compressions.
Can't feel carotid.
No febrile.
Receiving compressions.
Black band.
What's your next move, boss?
See, this is the other attending chiming in saying,
Yeah.
maybe we should
Nicely trying to do it.
exactly.
Then we can transfuse her with her own blood from the pleurovac to get ahead. Hang the cell saver.
So this is really cool. So the cell saver is what we use in the operating rooms, and this is basically when a patient's bleeding, they're extracting this blood from the chest tube that she's bleeding from, but they actually put it back inside the patient. It's called auto transfusion. So blood comes out of a patient, it goes back into the patient.
Hey, those look pretty superficial.
Might have been fragments from a ricochet off the ground. Just lost a lot of blood, but...
I haven't seen one pair of trauma shears out.
Yeah,
Usually trauma
to cut out
shears
the
are
clothes,
everywhere,
yeah.
cutting off clothes, getting exposure of patients. So that's a scenario where I would definitely cut at least up to the thigh to make sure there's nothing proximal or up higher.
Okay, 1 second.
What are you doing?
Checking the retina
For detachment?
for intracranial pressure by measuring the optic nerve sheath.
Is this...
I did a fellowship in ultrasound, and I'm just gonna this one. I don't know what they're.
Well,
trying to
he's a
do
med
there.
student, so this is okay. Maybe he's just trying.
Yeah, it's fine. So he's looking for optic nerve sheath diameter, which basically is behind the orbit. He's looking at that black spot, and he's measuring the optic nerve sheath diameter, which is a surrogate of intracranial pressure.
If the pressure's high, he could be bleeding.
If the pressure's high, it's going to be greater than 5. For the medical students out
But what's
there,
the sensitivity for that?
it's very low sensitivity and very low specificity. You have to compare it to the other side too.
Yeah.
I would not be doing this. This patient just needs a head CT.
Holy shit, 10 millimeters.
Super high. So
Yeah, 5. It's an intracranial bleed. The pressure's been building up. There's no blown pupil.
Yeah, not yet, but if he keeps bleeding in his skull, he's gonna die.
Yeah, he needs a 1-inch burr hole in his with a cranial drill. I'm just gonna see if neurosurgery's here.
yeah, so a burr hole is when you actually drill through the skull and to alleviate that pressure in the
What's
skull.
the safe place to do that?
So the safe place is usually right above the zygomatic arch in the temporal bone.
I got betadine and a 10 cc syringe.
Well, should we intubate, hyperventilate?
Mannitol decreases ICP.
Yep, so she just put an IO, and you can see that's that pink needle, so it's the shorter one.
Holy shit!
Relieving intracranial pressure so he doesn't die.
With an IO drill?
That's sick. I get the next one. What the fuck? Draining the ICH with an ECIO.
I love how they put the tegaderm over the
Yeah,
eye. So
yeah,
that's something
that's
we
gonna
do
do
on awake patients to make sure gel doesn't get in the eye, but they put a tegaderm over the
On
eye.
a non-awake patient.
There was a case report in the 2022 Journal of Emergency Medicine. Patient survived, went home neurologically intact.
The optic sheath is back to normal.
How did he figure that out?
I guess he put it back on the patient.
I think I'm feeling ephemeral.
I got a carotid. Emery, I got a chest case. Needs to go to the OR.
Saw you doing CPR. Let's go.
2 liters out of the left chest. Got a pulse back after 3 packed cells. 600 out of the cell saver, 2 of FFP.
I'm not feeling it.
Take a carotid.
Nothing, sorry.
Resume compressions. No, we should take her up. She just had a pulse.
Not now. We need a pulse go to the OR. Call me if anything changes.
Do we have any more whole blood from the donors?
Think so.
Okay, get another unit. It's got platelets and plasma. It'll help her clot.
Yeah, this isn't good.
Yeah.
If you're his co-attending, what are you doing? Are you pulling him aside?
So at this point, I think it's time for his co-attending to say, hey, let's swap out. Let's do this the right way, and let's make sure those resources are evenly allocated towards patients. It's such a hard move, and ethically, this is something that's so challenging, but I think it's the right thing to do for him to pull his coworker aside.
4 units. Blood is for the ones we can save.
She is right on the edge. One more can make the difference.
Looks like he's getting there, but hasn't done it yet.
I'm in.
End title looks good.
Okay, OR team can take it from here.
We need to check on the others.
I should get back to Pink.
Stay strong, Crash.
Hemostatic bandage still in place. How you doing, Carmen?
Not so great.
Okay, let's see.
It looks arterial.
Agreed.
Can you stop it?
Direct pressure for now.
Yeah.
We may have a junctional tourniquet in the disaster supplies.
How does the junctional tourniquet work?
So basically, think of it as like a pelvic binder. It's like a big belt that goes around, and then there's a balloon that you can inflate over the site. So rather than direct pressure, it's pressure
Both
through
sides,
the balloon and pushing on it. Yeah.
Whitaker, in the meantime, just put pressure on it to try and stop the bleeding.
For how long?
As long as it takes.
Got a better bandage, and we're gonna elevate your leg.
Do you know what's happening with my girlfriend? Her name is Leah. She was shot in the chest.
I'm sorry, we have a ton of patients, and they're only marked by numbers.
When Robbie and Dana were working on her, they were doing CPR.
How do you know Robbie and Dana?
Robbie and my mom were together for a couple of years, and I would come and hang out here.
Well, I'm sure if they're helping her, then she's in great hands.
Can you check for me, please?
Sure, of course, just after I finish this.
And this is so hard as a doctor. All the time, patients are asking
For follow-ups,
about their loved ones, and their loved ones might be very sick. But unfortunately, you're dealing with multiple patients. They might be asking, and you might not be able to communicate effectively with them. And in a time like this, you might need to just move on.
How much blood you pushing off the cell saver?
Every last drop.
ONEG, monitor the pulse. She's stable for trauma ICU if an OR is not ready. How many units so far?
4, plus the cell saver.
Last one.
I don't know. Dana, why don't we try a little TXA? 1,000 milligrams TXA might help her clot.
Got it.
So TXA is another clotting factor that you can give to help constrict blood vessels and cause clotting.
Bullet tore through her heart. Anyone else with a wound like this is pronounced dead in the field. You can't keep up with the blood loss. If she was our only patient, we'd do a thoracotomy, maybe ECMO, but even then, I doubt we'd get her back. We're gonna lose 10 other patients if you put all your efforts into saving this girl.
Got the TXA.
Okay, push it fast, then we'll do another pulse check, and then can you give me a vascular Doppler too, please?
How you doing, Carmen?
I'm hanging in there.
You want the circle of compression directly over the wound. Tighten.
And it's going to be uncomfortable.
100%.
If it's uncomfortable, it's doing its job.
Yeah, it's pushing into a deep wound, so it's going to be very painful.
Inflate the balloon. Come on, pump it up, Whitaker.
So that's that
How
balloon.
much pressure?
Until the bleeding stops.
And then that binder.
Right to pack cells, 2 of FFP, 1,000 of TXA, and 1,200 auto transfused. Did you check this?
Not yet.
What do you think of those chest compressions?
I think that it doesn't matter at this point.
I think so too. I like that she's elevated though.
Okay, it's working. More compressions?
Yeah, at least she's on top. He's really looking for a pulse. If you
Yeah,
can't
he's-
feel it palpably, that means that there's an issue.
Well, manual pulse checks, there's a lot of studies going on at my hospital, but manual pulse
Yes,
checks are not
notoriously inaccurate.
Exactly. So the gold standard is arterial line, but obviously in this scenario, you're not going to place an A line. So I agree with you. He's doing some heroic things.
And heroic in an unnecessary way, not
Exactly.
in a good way.
Yeah, in an overkill way.
Okay, we're done.
Stuff from 1947.
And normally when I pronounce a patient, I take a moment with the team to sit there, give a patient a moment of silence and reflect on our efforts
Yeah, but here you're
in the
losing more
patient's
people.
life. But there's no way to do this in this scenario. So it's so difficult for the team to recover from this and to just move on to the next patient right away.
What's up, Whitaker?
Junctional tourniquet appears to be working. No new blood on the gauze. You're looking good, Carmen. Carmen? Carmen?
Pulse is thready. How long has she been like this?
She was awake and alert a minute ago.
Oh, that blood loss is catching up with her.
Running a liter wide open?
What were they running before? If it wasn't wide open, she was bleeding
No
from
idea.
a femoral.
Huge collection of blood near the bladder.
The bullet missed a track north and hit the external
We
iliac.
stopped the bleeding near the leg, but she's still bleeding internally. We need Mal.
No, we need to give a unit of blood and move her to the red
Okay,
zone.
let me see if they have space.
What's going on? Leah's injuries were really serious. She stopped breathing. We put a tube down her throat to deliver oxygen. We were able to drain the blood that was collapsing her lungs. Gave her as much blood as we could. We even transfused some of her own blood that was in her chest. But we were unable to get ahead of the massive blood loss. Her heart stopped. You saw me doing CPR.
I wouldn't have done it now.
I think he needs to do other things.
Yeah, not even just from that standpoint, but he's just not going to be effective after this conversation.
Exactly.
Bring in a Mayo. How's she doing?
Still has a pulse. What are you doing?
Prepping for Raboa.
There we go.
Crazy. Did Abbott approve this?
He said, do what you have to do. Attendings are all tied up.
I would keep the tourniquet up until
The balloon
you're
was ready to be inflated.
Exactly.
Yeah.
Have you done this before?
So you're sticking in the artery, you're going in with that wire.
Like that.
Perfect. Looks a little bit brighter, so that's probably arterial blood.
Introducer sheath.
Santos is doing a Raboa.
Oh, no way.
Yes, way.
No, we need an attending or a senior resident for that.
First day of intern year doing a Raboa by yourself.
Yeah.
That's awesome.
Raboa, are you shitting me?
I told her to stop.
Uncontrollable bleeding from a pelvic artery. No other options.
We need an art line to know if the BP is up.
We'll go with pulse strength and mentation.
Carotid's weak, radial's barely there.
Another 3 cc's in the balloon?
Injecting.
I'll try for palpable systolic.
Yes, go for it.
So the pulses in the upper extremity should increase because obviously you're occluding the lower portion of the vasculature.
BP's 110 by palp.
That'll do.
Wound's dry, barely a trickle.
That's because there's no blood going to her legs.
Okay, the clock is ticking. Balloon can stay up for 1 hour tops. Get IR and vascular on the case.
And she's awake.
Hey, hang in there, Carmen. Hey, you're good, okay?
Okay, you never should have done that on your own, ever.
What? Would you agree?
I
think she
I
should
mean,
have
this
done
is
it.
pretty aggressive, but I agree that
The patient
she
was
did this
dead.
in this scenario.
Yeah. And she tried to get attendings.
Exactly.
Yeah. She was also the one that did the trigger points, no?
And the bifab.
Yeah.
That was pretty badass. You saved her life. Good job. I got their daughter killed. This is not your fault.
Yeah, he shouldn't be here. He's the most valuable commodity of the year.
This is what you do.
Oh.
I tried. I really tried. We all did. If this had been any other day, man. If it had been any other day, what the fuck does that mean? Any other day, what, you would have saved her life? Yes, no, I don't know. I don't know. We're getting slammed up there. We've had dozens of shooting victims. You've seen it. The fact that we've saved as many people as we have is a fucking miracle. But you didn't save Leah. No, I didn't. And I don't know how many people I've helped today, but I can tell you every other person who has died.
Have you ever gotten to a place like this?
I don't think I've gotten this far, but I tend to find myself getting more and more emotional with cases.
Now?
Yeah, now.
Why now?
I think as an attending, you can connect with patients and families a little bit better. As a resident, sometimes the workload is overwhelming. So I think as an attending, you feel the responsibility more.
Got it. So you're less thinking about, I got to learn, I got to get better.
Exactly.
And now your mind is more with the patient.
More with the patient and their family.
Do you think becoming a father has made it harder for you?
100%. I think connecting, especially with parents, has made my care a lot easier. Because now I can connect with what the parent is feeling during their care and during their kids' care. And
Do you use that? Do you say to the patients, I have my own children, I know what it's like?
100%. And the patients that do hear that phrase, they do appreciate it. And I think they do feel comforted that I know from not only the perspective of a physician, but also from the perspective of a father.
Fair.
There was a man named Mr. Spencer who died in front of his children, and an 18-year-old who was brain dead from a fentanyl overdose, and a guy with a heart condition, and a little girl who drowned trying to save her sister. And I'm gonna remember Leah long after you've forgotten her. Oh fuck! Oh fuck! I'm sorry. Sorry, you gotta go, man. You gotta go. You gotta go. You gotta go. I gotta go.
Wait, Robbie, wait!
You put him back in his bed, please.
So he's freaking out right now. He needs to definitely
decompress,
probably with the safety of another staff member helping him out, giving him some alone space, but also checking in on him.
Wow. So what happens?
Gotta watch episode 14.
Donald's
What a
gonna come back.
cliffhanger.
Yeah, Donald's gonna come back. Dr. Pettet was with us when we did our very first Real Doctor versus TV Doctor episode before the reaction videos. Click here to check that out, and as always, stay happy and healthy.